We're going to talk about intracranial pressure, what it is, and why it's so important that we keep it within normal range. So, intracranial pressure, or ICP, is the pressure inside the cranium or the skull. The normal pressure is 5 to 15 millimeters of mercury. Most of us are sitting between 0 and 5. Once you hit 20 or more, you're going to need intervention as soon as possible. Now, the basis for understanding intracranial pressure and what goes on in the brain is the Monroe-Kelly hypothesis. If you can understand this, everything else is going to make sense. So, Monroe-Kelly says that the skull is a fixed box. It doesn't expand or contract, so the total volume inside the box is fixed. It also says that there are 3 things within that box: brain tissue, blood, and cerebrospinal fluid. All of these things exist in certain volumes and proportions within the skull, and if one of those things increases in volume, the other 2 are going to have to decrease because there is no room, okay? It's a fixed box. Now you can see over here that there's this extra blood within the cavity because of a hematoma. And what happens is that puts pressure on the brain tissue. And you can even see that it's actually shifted the brain tissue over to the left. And it's collapsed one of these ventricles because that cerebrospinal fluid had to decrease, right? It had to get out because there was just no space for it to expand. The more that this blood increases, the more and more pressure that's going to build up because there's just nowhere for it to go. Eventually, this can actually cut off the blood flow or blood supply, either to the whole brain or to parts of the brain. And then it can even cause herniation. So what is herniation? Herniation is when part of the brain tissue is pushed or squeezed through a structure within the skull. So if you see here, there's been so much pressure because of swelling within the brain that it's actually pushed brain tissue through the hole at the bottom of the skull called the foramen magnum. That's one of the most common forms of herniation. And so this causes devastating damage to the brainstem. Remember, we talked about the brainstem controls most of the primitive reflexes we have, like breathing. So if the brain herniates through this hole, it destroys and cuts off the brainstem, and that can cause brain death. So ultimately, we want to monitor and control ICP so that we can avoid these devastating consequences. So what are we going to see if our patient has an increased ICP? Well, first and foremost, you're going to see an altered level of consciousness. Make sure you refer back to the LOC lesson for details, but one of the things we want you to be aware of is that sometimes these things are very subtle. Sometimes I'll even ask the family, is she acting like herself? Because sometimes that's all it is that they're just acting funny. We'll also look at pupils. We'll look at posturing. Remember the decorticate or the decerebrate posturing. We'll check for Babinski reflexes. And then sometimes if the ICP gets high enough, we may also see seizures. So we want to keep an eye out for that and make sure that they're on seizure precautions. Then the classic sign of impending herniation, which we know is one of the big risks, is called Cushing's triad. 3 things associated. The first is abnormal respirations. Now, this could be super high respiration, super low, or they could have what are called Cheyne-Stokes respirations, which is when they'll take deep breaths and then they'll take some small shallow breaths and then they'll take a few deep breaths and vice versa, so that it's this abnormal pattern of respirations, okay? The second thing is a widened pulse pressure. What's happening here is that the systolic blood pressure keeps going up and up and up because it's trying to improve flow to the brain. And so they'll go from 120 over 80 to 160 over 80 to 200 over 70. And so we see the difference between the systolic and diastolic is getting larger and larger and larger. Then the next thing that we're going to see is bradycardia. This is a reflexive bradycardia because it's trying to maintain a normal cardiac output. So the blood pressure is so high, the heart rate is going to start going down. And then the last thing we might see with elevated intracranial pressures is a high temperature. Now, when we talk about neurotemperatures, I'm not talking about 100.4. I'm talking about 104. They have very, very high temperatures. The reason being that the hypothalamus is what controls our temperature, right? So if there's increased pressure within the brain, it puts pressure on the hypothalamus and you start seeing these super high uncontrolled temperatures. So the main goals with our medical interventions are to decrease the total volume in the cranium, and that helps to decrease pressure. So there's 3 things that we can work to decrease. We can decrease the actual brain tissue, so that would be like swelling. We can decrease the blood volume, or we can decrease the volume of the cerebrospinal fluid. So one of the things we'll do is we will intentionally hyperventilate the patient. The faster they're breathing, the more they breathe off their CO2. And so we call this permissive hypocapnia. Now, CO2 is a vasodilator. So what we're doing by decreasing their CO2 is we're allowing for vasoconstriction of the cerebral blood vessels, which is going to help decrease the total blood volume within the cranium and therefore help decrease the blood pressure. The intracranial pressure. Then the second thing we'll do is we'll give things like osmotic diuretics. A good example of that is mannitol. The goal here is that it is going to pull fluid out of the tissue, and that will decrease some of the edema and the swelling, which again will decrease the pressure within the skull. We can also give hypertonic saline, like 1.5% or 3% saline, and that's going to have the same effect. It's going to pull fluid out of the tissues and help to decrease edema. And then finally, we can give corticosteroids. That's going to help decrease any inflammation or swelling that's going on within the brain tissue. And again, helps to relieve some of that pressure. So those are our medical goals. When we talk about our surgical goals, what we want to do is create room for the brain to swell. Now think about what happens if you sprain your ankle. It swells up, it expands, it gets bigger. Well, the same thing happens with damage to the brain, except it has no room to expand. So when we do see that swelling going on, we will choose some of these surgical options so we can make room for it. Now, one of those is called a craniectomy, and sometimes people will also call it a bone flap. What the surgeon will do is he'll go in and he'll actually cut off a piece of the skull and preserve it. And that allows for the brain tissue to be able to swell out through that hole that we just created without any increased pressure, so that it doesn't cause any damage to the brain tissue. And then as that swelling goes down, we'll replace that flap and secure it back in place. Now, the other option we have is great for patients with bleed or hydrocephalus, which is extra CSF within the brain. And what we'll do is we'll insert what's called an external ventricular drain, or an EVD. And what that is a catheter that's inserted through the skull into the ventricles in the brain. And then it's connected to a drain that looks like this one. Now, the doctor will order us to level it at a certain point, usually between 10 to 15 centimeters of water. And you can see here that 10 centimeters of water correlates to about 7 or 8 millimeters of mercury. So anytime the patient's ICP goes greater than 7 or 8, it will drain. If it's below that, it won't drain anything, but if it's above that, it's going to drain. So that helps us to maintain that ICP around 7 or 8. Now, you don't need to know too much about this as a new grad, but the most important thing you need to know here is that you never clamp this unless you're under specific instructions to do so by the physician. If the CSF can't drain, then the ICP is going to continue to increase, and that could potentially lead to herniation. So when we're caring for a patient with increased ICP, we need to do a couple of things to assess and monitor the patient. We, of course, need to monitor pupils and LOC. These are our basic neuro assessments. This is our staples for our neuro exam. Now, when we do those neuro exams, we're usually going to do them a lot more often than normal, usually every hour, maybe every 2 hours, but it's pretty often. Now, an important thing to note here is that we're actually going to avoid sedatives or any kind of CNS depressants, because we want to make sure we're getting a very accurate neuro exam and we know exactly what's going on. We also want to monitor their temperature and their electrolytes, especially if they're on any of those osmotic diuretics we talked about. They can affect their sodium levels. Now, our other interventions are going to be aimed at minimizing their intracranial pressure. First thing is we want to keep their head abed between 30 and 45. If they're laying flat, then that causes increased pressure within the skull and it can cause the ICP to go up. If they're sitting straight up, what can happen is you can increase the pressure within the abdominal and thoracic cavities, and that can cause trouble with the blood flow getting out of the brain and just causes increased ICP. So we want to keep them at that good range, 30 to 45 degrees. We're also going to decrease stimuli and decrease any Valsalva maneuvers. We don't want them being restless or agitated. We don't want them bearing down or coughing. All of those things can cause increased ICP. So we're going to give them things like stool softeners. We can even give them cough suppressants, because we want them to stay very calm and we don't want them having any kind of Valsalva maneuvers. And then, of course, if we do have an EVD or a drain,